Hi, everybody. I am with Dr. Siminsky. I am Diego Ruiz from Madrid. We are going to make this interview for the PBI Congress that is going to be in this year, at the end of the year. So this is going to be like the first step for the Congress, and he's going to give us some information, the good information that we will be aware this year. So, Dr. Siminsky, what do you think in the impact of the PDI guidelines that you use in the United States? And what if you do it in your practice day? Did you use it in the practice day, or do you do something else, or innovation, or what to do?
Thanks, Diego. Yeah, Eric Stumsky. I'm from Boston, Massachusetts. I'm a vascular interventionalist here, interventional cardiologist, and incredibly excited to be a part of and attending PBI this year. I think really it's some novel content, novel format, and will be one of the highlights of the year. We, like the European guidelines, we just updated our US guidelines that were released earlier this year. So we have a whole set of new peripheral artery disease guidelines, and there's been a lot of data that have come out in the US recently comparing endovascular and surgical strategies for CLTI care, but also how we manage patients medically. And so we use our PAD guidelines pretty strictly here in the US. They also help tell us a little bit about what insurers are going to cover, because our insurances follow the guidelines closely, and that's how we get paid for our procedures. But one big part of us in the US that changed in the guidelines this year is for medical therapy. So we now have for low dose Xarelto or rivaroxaban, 2.5 milligrams twice a day. That's now a class 1 recommendation to be used in patients with symptomatic peripheral artery disease in particular. And so I think that is going to influence a lot of people's practices. And again, we have a lot to sort out in terms of other aspects of our care, including when and who should get a surgical revascularization versus endovascular. But we now have more data on that than we've ever had before. And it's really an exciting time for clinical care and practice guidelines.
That is good. Maybe in the Congress, we can speak about the guidelines that you use in the United States and the European guidelines, and maybe we can share about the information that they have about.
I think that'd be wonderful. I mean, I think we need to align practices not only by our countries or our continents, but across the world. And so it'll be really important for us to review the similarities and differences and what's the best pathways for caring for these vulnerable patients.
Okay, thank you for the answer. I will ask you three more quick questions. Few questions, and you need to explain a lot because I know that you're very, very busy, Becca. Yeah. The next question that we would like to know is what do you think about the bioresorbable stents? What do you think about this? Is this innovation? Do you think in the future in this kind of stents?
Yeah. So this is a big area that's changed in the US also, is that we now have a stent, a bioabsorbable stent, the Esprit stent by Abbott Vascular that was approved. And that is really our first approved device in the US for both stents and even drug-coated devices below the knee. Right now, we do not have drug-coated balloons that are approved in the US for below the knee. And we have used off-label stents, like coronary stents, for many years. So having now a bioabsorbable scaffold that has drug on it that absorbs and that has an FDA indication for below the knee is quite the evolution of care for our patients. So we're really excited about it. It launched earlier this year, kind of in a limited release, and it's already become a fairly popular device. There are 2 other devices in the US currently being trialed, one by Riva and one by a company called R3. And these are also very nice, iteratively improved devices for what's now available. So we have a lot of excitement for this technology. There's a lot of interest in seeing where it can be applied elsewhere in the lower extremity, including in above the knee space, such as the SFA. And so everybody's really high on the bioabsorbables right now.
Very, 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 very good. The third question is going to be like also opinion that you explained me before, because you as a cardiologist you have worked with this kind of stuff before, and you know about this kind of products. So what do you think in this third question about the limus-eluting device in the below the knee in this sector that is very complicated for us because you have experience in the coronary, but for us, what do you think that the people that don't work with the sirolimus, what do you recommend that?
Yeah, this is a very important area. I think we've all used paclitaxel, and in the US, we only have paclitaxel drug-coated balloons for the femoral popliteal segment. And as I mentioned, we don't have any drug-coated balloons for below the knee. In the US, we just got our first drug-coated balloon for coronary intervention. We never had a drug-coated balloon, but all our stents use limus. And limus is a very effective anti-proliferative agent, but it's hard to deliver. And paclitaxel is a very effective anti-proliferative agent that's very easy to deliver, but has some downsides. And so, we've got a lot to learn and a long way to go. We've got a number of trials that are looking at these novel limus drug-coated balloons, and they've been able to take the limus and put them into vehicles, whether they're vesicles or nanoparticles, to more effectively deliver this treatment. And if what we think is true, we're going to see really impressive results, hopefully below the knee, where we're comparing to just a plain uncoated angioplasty. But we're also looking above the knee, where we're comparing the limus balloons to paclitaxel coated balloons. And we're going to learn a lot over these next few years of how competitive, how effective the limus balloons can be, and whether what our standard of care is, paclitaxel, can be outperformed, or at least be non-inferior with the limus balloons. So really interesting space. And I'll say both for the limus and for the bioresorbable scaffold is we only know so much in the first 6 months or a year, but we're going to need 2, 3, 5 years data as well. And I think this will be something we're going to be talking about for the next few years, whether in the Congress like PVI every year or in between, but we will be focusing really hard on understanding how to improve long-term outcomes and if these devices can get us there.
Thank you, Erika. And for finish this interview, you are going to give us some updates of the ongoing trials that we have information right now. You give us some pairs of some new information in this Congress about this new information.
Yeah, we're going to hopefully bring a lot of novel stuff to the meeting. Again, we're going to have a lot of updates and discussions about exactly what we're having a conversation on today. What's the right strategy? What's the future for below the knee treatment? Something I'll be talking about that is near to dear to me is how do we use intravascular imaging like IVUS more effectively for our patients? We've spent a lot of time working on this in the US. As an interventional cardiologist, we use this a lot during coronary intervention, and it's really important to us that it's used well, appropriately, and help improve outcomes for patients with peripheral vascular disease. So that'll be something else I'll be speaking on, and super excited for all the content in this really novel, forward-thinking meeting.
Well, thank you very much for your time and for your patience. And I hope that you have a nice day and see you in Paris.
Thank you, Diego. I'm looking forward to seeing everyone in Paris. Thank you.
Bye. Take care.